is my audience. We've got 1, 2, 3, 4, 5.
No,
Oh,
you gotta tilt up. No, other way.
like that. 5, 6, or sorry, 5 and 6. There we go. All right. Today I want to talk to you a little bit about psychological diagnostic techniques. I want to compare and contrast them, talk a little bit about their origins, their implications for therapy, drug treatment, and for private insurance. There's many different forms of psychological testing. Personality inventories, there are structured interviews, there's more projective tests like the Rorschach or the thematic appreciation. But overall, psychological tests come under one or two broad rubrics structurally, that being inferential diagnosis and descriptive diagnosis, like I talked about last time we spoke. What is descriptive diagnosis? Descriptive diagnosis heralds from the DSM, as produced by the American Psychiatric Association, published back in the 1950s. It's been revised 5 times all the way up till May of last year. What does the DSM and descriptive psychology do for the field? First of all, descriptive psychology and the DSM provide a basis for evidence-based treatments. That's to say, illnesses and disorders can be correlated with treatments that have been proven to effectively reduce their symptoms. Additionally, the DSM provides a neutral theoretical approach to disorders. That way, a doctor in California can diagnose a patient with a term which a doctor in New York or Texas would understand, regardless of their respective training and theoretical orientations. Additionally, and kind of to the bane of the psychotherapeutic field, the DSM also provides a sense of uniformity to insurance companies. However, insurance companies don't benefit from defining therapy as an open-ended relationship in which personal growth is encouraged. What is inferential diagnosis? Inferential diagnosis has its history beginning with Freud and the idea that the mind is not unitary, but is in fact often divided against itself, and it is multifaceted. Additionally, many of the motivations for our behavior are not always exactly in the forefront of our conscious volition, and we are not really necessarily always in control of ourselves. How do dynamic formulations work? The psychodynamic therapist attempts to understand the, for example, borderline or the anorectic patient or the psychopathic patient by identifying with the psychotic, the body-obsessed, or the sadistic portions of their own personality, respectively. This is necessarily a more intimate process than, per se, giving a person a Minnesota multiphasic, which is just a personality inventory with a list of yes or no questions. This form of diagnosis is also slightly more aligned with the traditional goals of therapy, which are things like establishing better control over your emotions and your emotional life, and allowing that to integrate into your overall functionality, or understanding our assumptions about the world and others and how those cause us to react on an unconscious basis. How does the dynamic perspective compare to descriptive psychology? There's really a great need in the psychotherapeutic field to think dimensionally about patients. For example, you can create a general concept like narcissism, but it's very difficult to study a narcissistic disturbance outside of the context of the person that it's occurring in. Additionally, there's a problem with taxonomic systems and comorbidity. That's to say, people who are diagnosed with the DSM rarely are diagnosed with only one condition. They're usually diagnosed with a number of them, which is only a problem if we insist on seeing people in an either-or sort of way, instead of considering that psychological preoccupations or issues can cause a whole host of developmental problems. For example, if you take the disorders anorexia and bulimia nervosa, disorders characterized by a preoccupation with fitness and food, or preoccupation with losing weight and fitness, respectively. Thought of as a continuum, these could be considered as going from bad to worse. And from a developmental standpoint, they can both be caused by an underlying obsessive-compulsive disorder. So in conclusion, despite the increased reliability through the revision of the DSM, the advances that have been made have actually been at the cost of diagnostic validity. That's to say, whereas a group of clinicians may arrive at the same conclusion, or diagnosis, that diagnosis may not actually pertain or say a whole lot of useful information about a patient. Whereas academic psychology is a science, psychotherapy is in fact an art. And the DSM may be an excellent research tool, but a reliance on it in the clinical psychotherapeutic field is at the expense of the humanistic portions of psychotherapy, which can't readily be operationalized or subjected to empirical research. Thank you.
Very good.